Hello, my name is Hayley. I'm one of the frailty practitioners at Frimley Park Hospital. So frailty is defined as a long-term condition characterised by a loss of biological reserve across multiple systems and vulnerability to decompensation after a stressor event. So if you think the types of patients that we see, they can be living independently at home or living with help and care and support. They have an atypical chest infection or a urinary tract infection, and then they will fall below the average line that you can see, making it an unpredictable recovery. And that's when frailty is more prevalent in those types of age groups. So if you have a look at the slide now, the relationship between age and frailty can be very different. So all of the pictures are showing patients over the age of 65. Your typical presentation of an older person may be the slides on the left, which is the types of patients that we would see at Frimley Park Hospital. But if you have a look at the right, they are even older, some of them, running marathons, doing physical exercise. We wouldn't necessarily class them as frail, so frailty does not always mean that they are old. So frailty presents in a number of syndromes. As a result of a stressor event, people with frailty present in non-specific ways and may have these types of syndromes present. So an easy way to remember what the syndromes are, we've put it into an acronym for you, an acronym of FRAIL. The first one would be falls. Second would be reduced mobility, function or decline. The third is altered cognition, delirium and dementia. Fourth is incontinence and constipation, and 5 is polypharmacy, but it's also known as lots of medications above 5. So what do we do? What is the integrated frailty liaison team, and why is it so important to have in a trust like this? So we are made up of elderly care geriatricians. We have one SHO, a nurse consultant for older people, advanced clinical practitioners, a physiotherapist, occupational therapist, a pharmacist, and we have admin. On a typical day, we would generally promote a front door frailty team. So we work alongside the existing MDTs in EDOU, which is now actually Majors Green. We see patients in a frailty crisis directly from ED, and these would have to present with one of the 5 syndromes that was mentioned earlier. Our first point of call always is to avoid admission. Any inappropriate admission. So we work very closely with outside community personnel like community matrons, clinics and the community rapid response teams. We manage risk slightly different. We're quite risk averse, so we would tend to try and always get patients home, even if another team may feel that it's slightly risky. We would safety net as much as possible. And we provide community follow-up. If the admission is appropriate, they will be clerked and post-taked by us. So that means we will see patients that come in through the front door on the ambulance trolley. We'll assess them there. They don't need to be seen by the ED team. So we've got enough expertise and clinical experience to triage patients ourselves, provide a management plan, initiate treatment, and organise their discharge without them going through the usual ED pathway. If patients are coming into the hospital, we then have the ability to direct them straight to the elderly care units or get them to a community bed if possible. And any patients that we feel are under a 72-hour admission would now go to G5 rather than G6. So our main ethos is that we work towards the Rockwood Clinical Frailty Scale. I appreciate that you probably don't see this much as an inpatient, but we work to this diagram in the ED department. So it's very visual, it's very easy to use. GPs use it, but in a slightly different way. So you can see there that there's pictures from very fit as number 1, right up to terminally ill, which is number 9. Whilst assessing our patients, we would match them against the clinical frailty Rockwood score and give them a score. So during the COVID peak, we used this tool quite a lot. So any patients that fell between a 5 and a 6, we would use it for clinical management of onward treatment within the hospital if they presented with COVID symptoms or were COVID positive. So as I said, it was used quite a lot within the medical team and the frailty team with the geriatricians to initiate onward treatment or advise on their ceiling of care. So we use as our clerking a comprehensive geriatric assessment, and you can see there the definition is a multidisciplinary diagnostic and treatment process that identifies medical, psychological and functional limitations of a frail older person in order to develop a coordinated plan to maximise overall health with ageing. The healthcare of an older person extends beyond the traditional medical management of illness, and it requires evaluation of multiple issues, including physical, cognitive, affective, social, financial and environmental and spiritual components that influence an older person's health. A CGA is based on the premise that a systematic evaluation of frail older persons by a team of healthcare professionals may identify a variety of treatable health problems and lead to better health outcomes. The document's quite lengthy, it's about 12 pages in all. As I said, it will go through all of those medical, functional, psychological and social problems, and we will develop a management plan from that. So what happens during the CGA? I briefly touched upon it in the last slide, but we will look at their medical presentation, so look at their past medical history, what diseases or illnesses that they have, any polypharmacy, medication and nutritional components that they have to the individual. We'll look at a functional assessment, so looking at their activities of daily living, how they mobilise with their gait and balance, activity and exercise status, along with psychological, so we'll screen their mood, look at their cognition, link in with the community mental health team to see if they are have any open referrals in the community. Look to see if they have dementia. We would look at a CT scan, look at the medication that they're on, discuss with family and relatives if their cognition has declined greater than 6 months. We wouldn't diagnose dementia in the hospital, but our geriatricians and us will formulate a plan for the GP and outside community mental health teams to follow, and we can order the right tests to get them on the right pathway to have their diagnosis done in the community. We'll look at a social situation, so any informal support, whether that be friends or neighbours that help the patient. Social activities and networking, so whether or not they attend day centres, community groups, and whether or not they're eligible for any care resources. So we link quite closely with the Iris hub in the hospital, identify early if the patient needs any care or support or additional care or support, and we can facilitate that ourselves. Looking at their environment, what they have at home, their personal safety, transport, use of any telecare, falls mats, and if they are accessible to any local resources. During the COVID pandemic, we have been going out to patients' houses and doing domiciliary visits. So everything that we do in A&E, we would go to their patient's house. It's worked quite well. We weren't really doing this pre-COVID, but as you know, the older person would generally fall into the shielded category. So our typical presentation of patients weren't coming to ED. So we decided that we would go out to see them. So a couple of practitioners would go out, complete the full comprehensive geriatric assessment, liaise with the doctors and community nurses and formulate a plan with our geriatrician back here at Frimley, take their bloods, book them into clinics later on down the line, or initiate treatment and medication right there in the home. So as you can see, I've put an evidence slide up. Patients identified when arriving in ED by the FRAIL acronym used to flag frailty syndrome presentations are the falls, reduced mobility, altered cognition and incontinence, and lots of medications, which is called polypharmacy. Patients are then screened for suitability for a CGA whilst in the department using the Rockwood scoring, used to screen all patients attending majors regardless of presentation for the stage of frailty. If reaching the threshold, will then be screened by us for suitability to be seen by the team. An assessment will then be completed and this information shared with the ICT. If a patient is not felt that meets the criteria for a full comprehensive geriatric assessment, we will still see them, but do it on a much shorter form, but they would still get their advice and still get some geriatrician input. Patients that are excluded would be patients who are coming in acutely unwell with an infection, acute cardiac presentations or major fractures. If they were fast positive, so a CVA and so on, and they will be referred to a more appropriate team for ongoing care. We would then see them as an inpatient, but we'll go on to that shortly. Patients scoring a Rockwood of 9, who are terminally ill with life expectancy around 6 months or less, we would still initially screen and clerk them, but we would then hand them on to our palliative care colleagues. So important liaison between frailty and palliative care teams ensure good outcomes for patients. Once we've completed our CGA, it is then scanned in ED along with their other A&E clerking and is stored on Symphony once they transfer to the wards. As you can see, a few statements of evidence there. By completing one of the CGAs, it reduces mortality, length of stay, readmissions and improves independence, reduces need for long-term care and increased patient satisfaction. It also lowers costs. If you look at it on the next bullet point, by doing 20 CGAs prevents one long-term nursing home placement. As I said, we provide a front door service, but once we've got A&E under control, we then concentrate on the inpatients. So you are able to access an inpatient geriatrician referral and a frailty team assessment. And you can do this by logging onto the intranet and typing in care of the elderly into the search engine, and it will bring up a frailty referral form. It's very simple and self-explanatory to fill out. You don't have to be a doctor to fill it out. Anybody from a care assistant, nurse, physio, occupational therapist, anybody that's looked after the patient and knows a bit of background on them and feels that a frailty assessment would be beneficial can use the form. We will respond within 72 hours and we will acknowledge that we've received the referral, but it may be a couple of days for us to get to the patient. So the idea of the inpatient frailty team is to support inpatients within the trust, patients that are not on an elderly care or ward run by a geriatrician. This can be on a surgical, orthopaedic or a medical outlying ward. We offer advice, general advice for looking after an older person, help with discharge planning. I do have capacity assessments written there, but we do encourage the wards to do their own. We can help guide and facilitate these assessments, but the patient is usually well looked after and known by the team that are looking after them, so we would encourage the clinicians to do their own. We can have a look to see if they're suitable for rehabilitation. As I said earlier, we do have direct access into Fleet and Farnham hospitals and can flag these patients up early so they can get a direct bed there. We'll look at their falls assessment. We don't necessarily have a fracture liaison service now, but we do have a surgical liaison service and delirium prevention assessment and management, and we offer advice on cognitive assessment, whether that be referring into the psych liaison teams or, as I said before, helping diagnose dementia, and we offer advice on incontinence. So I'm not sure if many of you know the term delirium. It's become quite prevalent in the acute trusts at the moment. CGAs are there to help facilitate and diagnose patients with delirium and help with their onward journey into the community. So delirium is a frailty syndrome and therefore likely to indicate that the patient has underlying frailty. The diagnosis of delirium is challenging, especially in the context of dementia and depression, and it is crucial that the diagnosis is correct. Incorrect diagnosis has resulted in patients being placed in care homes inappropriately and has resulted in legal action, so it is paramount that we get it right. There are new delirium guidelines which will shortly be available on the intranet with a delirium bundle to assist ward staff and an information leaflet for patients and carers. These patients benefit from a CGA in order to provide a holistic assessment and future care planning. Delirium can take up to 6 months to resolve, and it is inappropriate to keep patients in hospital for all of this time. It is challenging to arrange funding for patients with delirium as it is viewed as a health problem rather than a social care problem. The pathway is designed to support people who are unable to return home to their usual place of residence due to increased care needs and as a result of their delirium. It is to fund a temporary increase in care for patients where we think there is a reasonable chance of the patient returning to their usual level of function. The delirium pathway is for this very specific small cohort of patients. If a patient has delirium but is not impacting on their care needs and is able to return to their usual place of residence, then they do not need to be discharged on the delirium pathway. So delirium can present after a patient has had an infection, i.e. a chest infection, UTI or sepsis, can be post-surgery due to the type of anaesthesia that they have. So delirium patients can often present up on the surgical wards or the orthopaedic wards. In an ideal world, patients that are due to have this procedure should really be screened by the Frailty team to try and optimise their care prior surgery to reduce the risk of delirium. We did have a delirium team within the trust a few years ago, but unfortunately that isn't the case anymore. So delirium has to be diagnosed by a geriatrician. So all referrals need to come through the Frailty team. What we would need to help us diagnose delirium is a good collateral history from the family, whether or not their cognitive decline has been greater than 6 months. If it has, that would indicate the patient has a longer term cognitive impairment rather than acute presentation. We would request that the patient has a CT head if they haven't already had one done in A&E, to look to see if there's any involutional changes or any strokes or bleeds that could be the cause and reason for their acute confusion. And we would like a set of confusion screen bloods. This is all helpful for us to kind of diagnose the patient in the correct and proper way. So the overall benefit of having a Frailty team is that it's proven that 66% of patients assessed by the inpatient Frailty team have been discharged. This information and stats were actually last year, saving on average of 3,590 bed days per year. And that is, we were only a team of 5-6 people at the time, so that's pretty good going. 42% reduction in length of stay for inpatients after they had been clerked and assessed by us, and patients assessed by us in ED, or an EDOU as it was known then, which was the short stay A&E department, 24% were more likely discharged within 72 hours. Return on investment. So between admission avoidance from ED at Frimley Park last year, we saved at least £557,000 per year. That's a saving of approximately 1,555 bed days per year, saving on average in monetary value £434,722. By reducing the admission from EDOU to any other ward internally to the trust, we were saving £1,384,500 per annum. Length of stay reduced by 1.75 bed days, saving 2,035 bed days for the year. And when we're looking at G6, so pre-COVID, this was a short turnaround ward for elderly care. The length of stay reduced on that ward by 1.6 bed days, saving a massive £89,916. So that's us really in a nutshell. If you wanted to contact the Frailty team, we do hold a coordinating phone, which is 133596, and we're happy to take any calls over the phone and just offer some short-term advice, or as I said before, you can refer via the intranet. So now we're going to be showing you what we can't obviously do because we're face-to-face, is a Frailty empathy suit, which will demonstrate the impact of frailty that frailty has on the older person. And then shortly after that, we'll be displaying a link for you to go away and do some online frailty training. It will generate a certificate for you and will be classed as part of your ongoing CPD training.